Good evening. As a follow-up to the previous presentations on various crystalloids as part of the IV fluids ongoing presentation, today we'll talk about the lesser used crystalloids, which is your normosol, isolyte and hypertonic saline and 5% dextrose. This may not be asked in NEET PG, but there is a possibility it may be asked in the INISET or in the super specialty and in the fellowship exams, your FRCS and MRCS, including the OSCEs. So this is your template comparing the various IV fluids. We have talked about a few of them. In this slide, we are going to talk about normosol and plasma light. So you look at the sodium, it's definitely lower than normal saline. Chloride is also low. Potassium is there. But instead of calcium, magnesium has been introduced. That is the only standout factor, and buffers are always there so that they prevent acidosis. And you can see the pH is quite in the safe higher value. Now these are not as popular as resuscitation fluids, but you must remember that there is no calcium here. So naturally, all this chelating the citrate will not be there, and you can use them to dilute RBC transfusions. Now coming to plasma light A, has a lesser tendency to promote interstitial edema when compared with normal saline. This, even though the sodium is 140, for reasons unknown, it produces less interstitial edema. So normosol and plasma light lesser used, but they have their specific scenarios where they are very helpful because they contain magnesium, and plasma light has a lesser chance of interstitial edema. Now coming to hypertonic saline. You would have heard about hypertonic saline being given to correct hyponatremia, being used to correct brain edema. Let's see how far it can help in correcting volume in the intravascular compartment. So the striking feature will be very high sodium and equivalent chloride ions. And pH, look at the pH, it's almost the same as that of normal saline. But the osmolarity is about 8 to 10 times that of the sodium chloride, normal saline. Now, what are the places where you can use them, or can you use them at all? So have a look. It has very high osmolarity, and it is very effective in expanding the extracellular volume than isotonic crystalloid fluid. See, it has a very high probability. Now, this extracellular fluid gets increased because a lot of intracellular fluid is added to the volume. There is so much of sodium in the interstitial space. As usual, they will leave the vascular compartment, go to the interstitial space. From there, they will draw water from inside the cell and expand the total extracellular space. So what will happen? It will cause cell shrinkage. But the only thing is, in a very small volume, it can rapidly expand the intravascular volume when compared to isotonic saline. So small volumes, especially in trauma victims and in the pre-hospital phase, when you want to correct the intravascular volume very quickly in the field itself, you can probably try hypertonic saline. But at the end of all these deliberations, hypertonic saline is not used for volume resuscitation. It may be used to correct hypernatremia. It may be used to correct raised intracranial tension, but never to correct volume. Now, what about the other one, the last one, which is 5% dextrose solutions? Previously, when enteral feedings or total parenteral nutrition was not available, patients need some basic calorie so that they don't lose their muscle mass. So dextrose was being given to give that non-protein calorie and thus save the protein. But now what is happening, you have TPN, you have enteral feeding, you can give that calorie through those feeds instead of using dextrose, because what will happen, dextrose also will move here. Now when it moves here, it will get metabolized and it will go into the cell and get metabolized and also take the water in. So you will have cell swelling, which may not be homeostatic. Or if this dextrose is not being used in a critically ill patient or in a diabetic, it will stay here and shrink these cells. See, it acts both ways. It can either swell it up or shrink it. So there is a lot of pericellular activity there because your dextrose here is very high. So what are the other problems? Lactate production. Your dextrose, when there is no enough oxygen in the blood, will get converted into lactate. So you have a lactic acidosis, especially when critically ill patients will have certain amount of hypoxemia secondary to hypoperfusion. So you have two things. It goes into, there is no more, we cannot use it for protein sparing effect because we have got feeding options available. Number two, it increases lactate production. Lastly, hyperglycemia has serious problems up to mortality also. So what is happening? Don't not only avoid it in the ICU, but it is even being, because in the ICU you need very strict glucose control. Now, if this dextrose is going to push up your blood sugar, you're not going to use it. So it is being, please avoid whenever possible. In fact, even some fluid enthusiasts ask for abandonment of dextrose solutions in the ICU unless strictly indicated. So in summary, normosol and plasma light have magnesium, so can be used in RBC transfusions because calcium will chelate the citrate, which is used as an anticoagulant there, and you'll have clots in the RBC bag. Hypertonic saline has no role in resuscitation of volume expansion. We have told this. Dextrose containing fluids will cause cellular swelling or cellular shrinkage depending upon the metabolism of dextrose in the interstitial space. Lactate levels will increase. Hyperglycemia has very deleterious effects. So it is almost abundant in the ICU. So this is the brief about lesser used crystalloids. You need to have a brief overview of these fluids, those three fluids which I told you about, and hopefully it will help you in better clarity. Thank you very much. Please do share, subscribe and like, and also join my Telegram channel because there is a quiz particularly on IV fluids going on there. So please do join my Telegram channel.